Hello everybody, welcome back to DaVinci Academy's Chapter 7 unit of the head and neck. Here we're going to be talking about the musculature of the head. So this is a rather short chapter, it's actually not too bad, so we're just going to go through it pretty quickly here. So, the musculature of the head is actually primarily involved in all the muscles of facial expression and actually helps define the unique characteristic features of each person. I think it's very interesting because all these muscles actually don't have a very similar insertion or origination as all other muscles in the axial system of the body. They actually do a thing called interdigitation, in which the muscle fibers are actually, pretty much as you're thinking about crossing your fingers like a mesh work, they actually will cross across the other muscles or into the fibrous fatty tissue of the face, and that's how they kind of actually work. And that's how they actually are able to create this nice fluid facial expression movement with things like elevation, depression, dilation, narrowing, and opening and closing without being very fixed, hard, sharp movements. So it's actually very fluid and natural. So before we talk about all the muscles, it's very important that we talk about the scalp and the facial layers. So the face, the scalp, the neck, again, like we mentioned before, is what we call this connective tissue, this fascia that actually continues throughout the whole body. But it's very unique in the face and the scalp that it's actually kind of different. And so it's actually helpful that this fascia is known about because it helps with form and function for a lot of this musculature, a lot of these fine movements. So the face and the scalp, most notably the scalp, is divided into what we call 5 successive layers. The skin, the connective tissue, the aponeurosis, the loose areolar tissue, and the periosteum. I think the mnemonic scalp is great because it actually helps you break this down pretty easily. And again, all this also exists in the face, but again, the face is so complicated and so in-depth that you probably don't need to necessarily know about all these fine layers in the face unless you're going to know something like plastic surgery, of course. Then you would need to know these different layers of the face. So with these layers, if you can see over here to the right, it kind of drew it out. Imagine if this is the scalp, and then this is kind of, if you do a cross-section of the scalp, this is what it would look like. The first one is the skin. It, of course, has the 3 layers that you know about. It also has the site and hair follicle growth. So you have the epidermis, the 2 layers of the dermis, and you also have the hypodermis, that's subcutaneous fat. Then you also have the connective tissue, which is the site of all the subcutaneous fat insertions with the fibrous tissue and the neurovascular structures of the skin that course throughout it. All the blood vessels, all the nerves for sensation run through the connective tissue. Then you have aponeurotic layer, also called your galea over here. And it's a portion of the scalp that continues with the muscles of the frontalis, as well as the occipitalis in the back, as well as what we call the SMAS that we'll discuss in a second. So it's continuous with this layer. And whenever you have some sort of cut or lesion and you need to kind of close this for any reason, the best option is actually do an undermine where you cut and you release underneath the galeal layer, the aponeurotic layer, and then you can actually try to do a primary closure by just coming together the aponeurotic layer. And then you also have the loose areolar tissue, and this area is actually used for a planar dissection during craniotomies and craniofacial procedures. But it's because of the fact that you can actually slide and move really easily underneath this loose areolar tissue. It's actually important because of that, infections can actually move and slide under this area as well. And of course, like all muscle has, you have that periosteum, that little thin layer that lies right above the skull, throughout the whole skull. So now we'll talk about the blood supply to the scalp and the face. So the blood supply to the whole head is so highly vascularized. If you have even a minor cut on your face, you're going to bleed, and you're going to bleed pretty considerably. It's never going to be a life-threatening bleed unless it's pretty deep or one of the major vessels, but you're going to actually bleed more than you think you would. And if anyone's ever had like a pimple or something on their face or a little scab, and they picked it and they bleed, and they don't know why they're not stopping, it's because the blood supply to the head and scalp is so highly vascularized. And so what's important is that the scalp actually receives 5 different arteries that provide blood. And then across the top of the scalp, you have a lot of anastomotic branches that cross over like this. But the 5 big branches are, you have your superficial temporal, you have your posterior auricular, you have your occipital, and those 3 all come off the ECA. And then the other last 2 are the ones that come off the supratrochlear and your supraorbital. So these 2 right here also are ones that come off of the face, the front of the face. And these are important because they provide blood to the forehead, the whole front portion of the scalp, but then will form anastomotic branches over here with the superficial temporal arterial branch. So when we talk about the scalp and facial layers, we're also going to mention about the sensory supply to them. So sensory innervation is important, and it's actually divided into the cranial nerve segments as well as the cervical nerve contributions. So the cranial nerve contributions provide sensation from the forehead to the vertex of the scalp. So you have your supratrochlear nerve, you have your supraorbital nerve, which both come off of V1. You have your zygomatical temporal, which pretty much provides sensation to the zygomatic and temporal region via V2. And you have your auriculotemporal nerve, which comes off the mandibular CNM V3. Then you have your cervical nerve, your cervical plexus contributions, things like your lesser occipital nerve and your greater occipital nerve that provide innervation to pretty much a lesser portion of the posterior scalp and then a greater portion of the posterior scalp. And that's how I kind of remembered it, both of C2. Now we're going to talk about the musculature. So a lot of the musculature in the head and neck is actually tied off between two different groups. You got your muscles of mastication and then you got your muscles of facial expression. So we'll talk about the muscles of mastication first. These provide all the movement for the mandible and the temporomandibular joint. And the axis of movement is pretty much up, down, and left, right. That's pretty much the whole movement the muscles of mastication can do. These muscles have a bony side for origination and insertion, similar to all the other axial and extremity muscles, so they do differ in terms of all the muscles of facial expression. And they are derived from the first pharyngeal arch. And like all first pharyngeal arches, it's innervated by cranial nerve V3. So all your muscles of mastication, your temporalis, your pterygoids, your masseter, they're all innervated by the mandibular nerve. So the facial muscles, which is the next group of muscles here we're going to talk about, there's so many. There's actually, quite frankly, a lot of facial muscles. And they're very different, like we mentioned before, from the axial and extremity, even the muscles of mastication, because they don't really share these bony sites of origination and insertion. They actually insert to this fibrofatty connective tissue, the skin fatty tissue layer, and also the superficial muscular aponeurotic system, the SMAS system. And that's what makes it so unique, and that's why you get these very fluid movements. So the muscles of facial expression, just to reiterate, are the only muscles in the body that insert into the skin. All of the facial muscles used are only innervated by cranial nerve 7, facial nerve, and that's it. All the muscles of facial expression, even the platysma, everything is all cranial nerve 7. So embryologically, just like everything from cranial nerve 7 and the facial nerve, they all come from the second pharyngeal arch. So their namesake for the facial muscle often contributes to what their function is, and which is why it's so great. If you're going to actually try to go in depth on what each of these muscles are, by all means do it. It's a great topic to learn about. And by just knowing what the name of these muscles are, you can pretty much figure out where they're located and what they do. So for example, the oral region, you got your orbicularis oris, which is the mouth, that wraps around the mouth. Over here you can see this is orbicularis oris. You also got your buccinator as well that comes off and inserts into the cheek region, deep. In the lower lip, you got your depressor mentalis, your depressor anguli, depressor labia inferioris, and platysma. So I'm pretty sure you can assume what all these muscles do. They help with depression of the lower lip, help you frown. Then you got your upper lip, so zygomaticus major and minor. As you can imagine, this is your zygomatical area. That's going to be zygomatical major and minor are going to be somewhere in this region. As you can see, there's one right there. You also have your levator labii superioris, levator labii superioris aliquae nasi, which is the longest named muscle in the human body, and then your psorius. So these are all muscles that are located pretty much right approximately here, and they help with elevation of the upper lip. They help with dilation of the nose. They help with retraction of the nose, flaring out of the nose as well. So that's kind of just mid-face functions there. So again, in terms of if you need to know all the musculature of this region, that's kind of up to whatever you're learning it for. If you're going to go into something again like plastic surgery, of course, all these muscles are very important to know, and their form and function help. Then you're going to talk about the nasal region itself. You have a muscle called the nasalis, which actually runs across the transverse portion of the nose, like in this region, right across the nose, and that actually helps with flaring out the nose with breathing as well. You have your, again, that levator labii superioris aliquae nasi, and that pretty much runs pretty much from the upper lip right here all the way up this way, and that's that muscle, and that helps again with flaring out the nose, elevation of the lip, elevation of the nose. Then you have your procerus and your depressor septi nasi. So again, probably not necessarily the most important muscles to know in the whole body, but again, these are important for the nasal region. And of course, your final one is your ocular region. You have your corrugator and your orbicularis oculi, which is very important, especially with that blink reflex. So we're talking about all the muscles of the facial expression, how they're all innervated by the facial nerve. We might as well talk about the facial nerve itself. So as you've probably seen this picture from a previous lecture, you got your facial nerve and its 5 branches. So the facial nerve exits from the external auditory meatus, and the immediate branch that goes backwards posteriorly is the posterior auricular nerve, and that provides sensation to that region right behind the ear. All of the other branches are what contribute to the motor function of the facial nerve. So it has 5 divisions that branch within the superficial and deep lobes of the parotid gland. So if you can imagine, the parotid gland would pretty much be right around here. And this is where these 5 branches will bifurcate or split off. And it's important because the facial nerve, since it is so intimately involved with the parotid gland, can actually get injured in any sort of parotid infiltration, whether it's an infection, neoplasm, whether it's even during surgery, something like a facelift or a surgical dissection for a parotid tumor. And again, just to go over it again, your branches of the facial nerve are your temporal in blue, zygomatic in orange, your buccal in yellow, your marginal mandibular in green, and then your cervical in red. There's a lot of different mnemonics to know about what the branches of the facial nerve are, but the best way to know about it is to just think which regions of the face need innervation. Your temporal needs it, your zygomatic, your cheeks need it, your mandible needs it, and of course your neck for the platysma need it. So again, your temporal branch innervates the frontalis, the orbicularis oculi, the corrugator, and it also is the efferent arm of the corneal reflex, that blink reflex. And you can test this by having someone frown or wrinkle their face or lift their eyebrows nice and high. And the zygomatic branch, this is one that's an orange, innervates the orbicularis oculi as well, and this helps with closing of the eyes, closing them nice and tight. That's a big one for the orbicularis oculi. Yellow one over here, the buccal branch, innervates a lot of those mid-face muscles, so things like your zygomaticus major minor, your levator labii superioris, buccinators, your orbicular oris around the mouth, visorius, levator labii, superioris obliqui nasi, transverse nasalis, and of course the depressor nasi. So a lot of those nasal muscles, those nasal involved muscles, and those upper lip muscles are all pretty much buccal branch. Then you got, and also to mention, you test this by blowing a bubble or telling someone to smile. And you have your marginal mandibular branch. This innervates your depressor labii inferioris, your depressor anguli oris, and your mentalis. This is the one where you actually have them over-accentuate lower lip depression, just having them over-accentuate a frown. And that's how you can test this one. And the last one is your platysma, and this is when you tell them to over-exaggerate, to accentuate a very large frown, and then you can actually you try to contract the platysma, and you can actually even feel your deltoids or your pecs actually kind of tense up as well. So now we're going to go over some clinical pearls relevant to this chapter. So when we talk about the facial nerve, you always got to talk about Bell's palsy. So Bell's palsy is when you have denervation or disruption of the facial nerve in any way, for any reason, causing visible facial paralysis. So it can present in multiple different ways, anything involving the facial nerve. You could have facial weakness, twitching, you could have total paralysis, almost like a stroke-like symptoms. You can get ptosis of the eyelid because if you have decreased orbicularis oculi innervation. You can get ptosis at the angle of the mandible because your marginal mandibular is not working, inability to smile or frown because your buccal and your marginal mandibular aren't working right. You can even get decreased sensation to the skin posterior to the ear if it's involved in the facial nerve injury that proximal. So Bell's palsy is considered to be a lower motor neuron lesion with unknown etiology. It's not considered upper motor neuron lesion, so you're not going to get that discrepancy between the forehead working and the lower mid-face not working. You're going to get complete unilateral ipsilateral loss of facial nerve involvement. So even though the etiology is not known, there are definitely some situations that have high clinical association to them. Things like VZV virus, EBV virus, Lyme disease. You could have iatrogenic causes, again, like facelift surgeries or parotid dissections, or even in idiopathic trauma for some reason you can damage the Bell's palsy. And of course, prognosis is not always guaranteed, but sometimes it actually can come back and work again because peripheral nerves do have the ability to regrow, but again, prognosis is not guaranteed. It's case by case. So we're going to talk about that SMAS system that we mentioned before. So the area of face, this is probably considered one of the most important components in terms of someone who's aging, or the aging face. This is the third layer of the face, and it's continuous with the region of the scalp, the galeal layer. So the SMAS is often manipulated and can use, this is what you do a facelift. You access it right behind the ear, right behind the sideburns of the ear. You dissect the face out, you access the third layer, and then you can actually tighten the SMAS and create a nice, strong retraction and make the face look more youthful. The SMAS also is continuous superiorly with the galea. It's also continuous laterally by your temples with the temporoparietal fascia, and it's also continuous inferiorly with the platysmal fascia inferiorly. So we're talking about aging faces and the structures of the face and the muscles. It's also important to talk about the retaining ligaments in the face. This is probably one of those things that's actually very, very infrequently taught in medical school and other clinical situations. So the retaining ligaments of the face are these fundamental components that are pretty much ligaments that actually help with supporting the facial muscles and the connective tissue. And these are located in the fourth layer of the scalp, quote-unquote scalp mnemonic, but it's present in the face as well. And these span the length of the layer. So they're not just that they're present in the fourth layer, but they actually span the layer. So if you have 4 layers like this, it actually will span the length of the layers. This is a ligament and attached like this to help with stability throughout all these points. You can actually release these ligaments and help free up the face to actually have greater traction, especially doing something like a facelift. And there's actually considered to be 3 true retaining ligaments: your zygomatic, your masseteric, and then your mandibular. And the thing is these are all easy enough are in a straight line, and that's actually really unique how clinically they're related. So you have all these in a straight line. And the last 2, of course, are your superior and inferior temporal septums or septi, and then you also have your temporal adhesions. And you also have your lateral orbital thickening as well, your adhesions as well. located close to the eye or in this region here. But these aren't considered to be true ones. The true ones are the zygomatic, masseteric, and the mandibular. And that concludes DaVinci Academy's unit here on muscles of the head. And if you any reason, need to go back and you take it a little bit slower, you want to learn anything again, feel free to rewind it and go over it again. Thank you.